Good morning, everyone, and welcome to our second session of CME Palooza. I just have a very brief story. I just have to say that a couple years ago, I had the very first session of the day, and I can see when people are, tuning into the session, and the number was at 0 and no one was coming on, and I always get a little freaked out at the beginning of all these sessions until I see that people are actually watching. So it always takes me a moment to get going. But anyway, thank you all for joining us. We have our slides. So this is our Grant Anatomy 101 session, dissecting a grant proposal. This session is sponsored by Creative Educational Concepts and MedLive. Our moderator is Mike Lopresti from Vindico Medical Education. But before I turn things over to Mike, let me go through our sponsors. Our gold sponsors, Med Learning Group, Medscape Education, Kaplan Medical Education. Our silver sponsors, Academic CME, Daiichi Sankyo, Creative Educational Concepts, GKB Med, Global Learning Collaborative, Helio CME, HMP Education, MedLive, Prime Med, Talem Health. And our bronze sponsors, Answers in CME, Bonum Continuing Education, CMEology, Excalibur Medical Education, Global Education Group, Infograph Ed, Integritas Communications, Iridium Continuing Education, Paradigm Medical Communications, Partners for Advancing Clinical Education, Peerview Institute for Medical Education, QDCME, the last two, Vindico Medical Education, and Write CME Pro. Two different ways that you can ask questions during CME Palooza. You can use our CME Palooza text line to send in a question, 267-6660-CME. You can also open up the little viewing window in YouTube, and you can participate in the chat within YouTube. And if you ask any questions or comments within there, I'll be monitoring those as well. This is a pretty open, informal session, so questions are encouraged from the audience. We'll get to as many as we can. We do have a lot of other things to cover, so I think the panel will try to get to as many as possible. Interact with Poll Everywhere. We're actually not using Poll Everywhere during this session, but I think we are with all the others. So you don't need it for this one, but never hurts to get yourself ready for the next session. So you can either use the Poll Everywhere app, download it if you need to, and then join the presentation that's titled CME Palooza 005. Or you can also just plug in the Polev URL into your web browser, polev.com/CME Palooza 005. And then the last thing from me is our speaker disclosure. Any opinions, discussions, and or conclusions expressed are those of our panelists and do not represent an endorsement by or position of their employer, its parent company, or affiliates. And so with that, I am going to turn things over to Mike. Take it away, Mike.
Thank you, sir. I am very honored today to be joined by my esteemed panelists. I'll just run through everybody and save some time on introductions. We have with me Ryan Fuller, Medical Education Grant Officer from Lilly, Maria Deutsch from Bristol Myers Squibb, the Medical Education Oncology side, Priya Muley from Gilead, Director of Medical Education, and Nish Mehta from Sumitomo, Associate Director, Grants and Sponsorships. So our goal here is really to go through, as the title says, the anatomy of a grant, look through the various different parts of grant proposals, and then I get to torture my panel with all kinds of cool questions about how they do, what they look for, what's great, what's terrible, what works, what doesn't. And leading up to this panel, what we did, with thanks to Derek and Scott, we put together a survey, put that out through the CME Palooza channel to ask, what are your questions around grant proposals and the different sections of the proposal? And we structured that with some of the kind of standard sections, and you'll see that's how our panel will run today. So we got about 25, I think it was between 25 and 30 responses, lots and lots of questions. We'll never be able to get through all of them today, but we did kind of see some key themes as we went through, and that's where we're going to start. So I think the first important question, just to kind of set the tone of where everybody is I'm going to go around the horn and ask everybody, how does your company manage grants? I know some people do RFPs, some people wait for organic grants to come in. So Nish, why don't you start? How do you handle that?
Yeah, sure. So our process, we basically start the year as we're starting to plan for the following fiscal year with developing our areas of interest internally. Those will get reviewed by our strategy leads, legal, and then posted onto our grants portal for providers to be able to get general guidance for our different therapeutic areas. From there, it's just on a rolling basis, unsolicited requests throughout the year, so organically. And we review, depending on the therapeutic area, anywhere between 4 to 6 weeks, depending on what's come in. And that's kind of our process.
Very straightforward. How about you, Maria?
So nice to be here. Nice to talk here with everyone and answer some of these great questions that came in. So our grants portal is Cyber Grants, and it's open 24/7. So most of our, and on our IME page, we have our areas of interest. So most of our grants do come in organically. There are times throughout the year that we post RFEs, and that information is also on our grants portal. And the RFE consists of 3 or 4 pages of what we're looking to educate in and what we think are the needs for that particular topic. Once they come in, they're triaged into different therapeutic areas, and it goes across to my various IME colleagues, and we review them and approve or decline. So it's both ways.
Good, a mix. Now, Ryan and Priya, I know, having talked with both of you, obviously preparing for this, you do it a little bit differently. You have a somewhat limited number of providers that are invited to submit, and sometimes it's RFP. Priya, you have a very interesting process at Gilead. Ryan, why don't we start with you?
Sure. So we do develop IME strategies, like the previous 2 panelists mentioned, where that's where we kind of our priorities are agreed upon there with our medical affairs teams. We also use that to create like our educational priorities, and those are what go on the grant portal, so everyone can see the priorities. But those are very high level. The IME strategies we develop, those are what we use to create the call for grants. And our process is really 98% of what we fund is through call for grants. And we do have a minimum number of providers that we have to send it to it's agreed upon by legal, the number, but they still consider those unsolicited or but we also accept non-call for grants in the portal, and ours is open all the time as well. But we just have realized over the years that it's usually we get more targeted proposals that are aligned to the strategy if we use the call for grant process. Oh, and then one last thing, sometimes we post the call for grants, but we don't post them on our own site. If we do that externally, it's on the ACCME site, but it's very, very rare that we post them.
Gotcha. And Priya, last but certainly not least.
Thanks, Mike. So yes, we do have kind of an interesting process here at Gilead. We have what's called our needs and concepts presentations, and I would say that most of our budget is allocated through the needs and concepts presentations, and those take place every summer, typically between June through mid-August, and we are looking at proposals for the following year. So for example, in this summer, we looked at proposals that will be taking place for next year, for 2026. And so those are providers that have demonstrated outcomes are invited to present at these 1 hour and 15-minute presentations. And typically the way that the timing is split is we encourage providers to spend 15 minutes talking about the needs and the gaps. And then we encourage them to use the majority of their time to spend that on the concepts that they have developed to help meet those gaps. And then, of course, depending on the therapeutic area, for like the 1 hour and 15-minute presentations, they're allowed to pitch up to 8 concepts. And then the timing and the number of proposals that they are allowed to pitch might change just depending on the therapeutic area, how big the therapeutic area is. So that timing and number of proposals might get tweaked. And then we also we do occasionally put out some RFPs. For example, if it's something like satellite symposia, we might use the RFP process for that.
Great. All right. So now we have some context around that. Let's get to the question that is really just scratching the back of everybody's brain. Well, I mean, from a provider side, it's scratching my brain. Do you guys actually read the portal fields, or do you just read the proposal? This is important stuff. Maria.
I'll start.
ahead.
I'm bursting at the seams. I'll start. Every grant that comes into my portal, the full grant proposal, I read. I do. I read. I go all the way. I go through it. Every once in a while, I'll go, if I have to summarize the grant, if I'm presenting it to someone, I might use and cut and paste where the learning objectives are or where the summary of the grant is in the LOR. But reading the grant full through is something that I do. So I know that it takes a lot of time to put a grant proposal together, and a lot of people are involved. So I do give it that grace to go through it. Now, if it's aligned with strategy or not on me, on you, that's another thing. But I do go through the grant and the budget as well.
All right, anybody different from that answer? We always just on our side go, oh, we're putting all this stuff in the portal fields. Is that what they're reading? Are they reading the proposal? Is it both? We're never sure.
No, I can chime in there, Mike. So I know we get like a little bit of like kind of like a sneak peek and a preview of, you know, the grant proposal because we're hearing you guys pitch proposals live at the Needs and Concepts presentation. But I do want to reiterate what Maria said. We do go through again and read through those proposals when they come in. So I like to kind of start with the full proposal that you guys have developed and attached. I think that that's a good starting point for me. And then I will reference back to the grant fields as appropriate, but it is really helpful to have that full proposal in there. And I think it's a good starting place for me.
Okay, well then let's move on to the next, actually a very important question. What do each of you consider the make or break section of the proposal? What is going to catch your attention? Where do you go first? This is something that we got a number of questions on, a little bit different with each question, but Nish, why don't you start? What is most important to you?
Yeah, I think several
shows that they get it.
Yeah, I think it's several pieces of the grant, right? For me personally, in my role, right, I work across multiple funding areas, not just medical education. So I think that executive summary is really important for me to really take a look at to get a high level summary of the grant in totality. For us, the first decline place is areas of interest, right? Making sure that the grant aligns with our educational objectives. So if going through there, it's already clear that this is not a grant that aligns with our strategy, then it's a pretty easy decision. It's not something that we're going to send to our GRC to review. So I think that area is really, really important. And specifically with the GRC, right, this is a cross-functional group. It's not just me or just us that's approving these grants. And those people include medical directors, strategy leads, and are also being pulled in many different directions. So for them, going into a committee meeting, being able to have that high-level summary too, because I mean, as much as we'd love for them to read through the full grants as well, they just don't always have the time to. So I think that's a really important piece of the grant. Additionally, kind of tying the gaps and needs with learning objectives, we see kind of those charts more and more. Making sure that everything is aligned throughout the grant, from gaps to learning objectives to outcomes. And then finally, I think the agenda is really, really important. That's something that we always look at on our committee meetings to make sure the topics being covered, again, kind of align with our areas of interest.
Yeah, Maria, you said the agenda when we had our the agenda was important too.
So of course, you have to have the budget, right? You can't play in a big boy's place unless you have money to back it up, or a big girl's place. So if a grant comes in and it's $500,000 and I just don't have that amount, you got to put your thinking cap on and say, well, how much multi-support is needed? But say I get past the sticker shock. The first place I do go is I have to make sure that it's aligned with our medical strategy, right? And learning objectives are nice, but they could be very high level. And I understand why they need to be high level, because a lot in the grant could be part of that. But a very well written and flushed out agenda is kind of the best part of the book for me. When you go to the end of the book and read that first and then start at the beginning. So the agenda is something that I could really wrap my head around, because it gives me an insight of what you, Mike, and your colleagues are thinking about actually putting in that presentation. There's just, there's compliance, and there's just so much we can have a conversation about. But having a good agenda and it being as detailed as possible is something that for me works well. Not necessarily a lot of people, but I'm seeing more and more well-written agendas. So something's resonating, and I hope it continues.
I want to get to Priya and Ryan with this, but I see Derek Warnick has joined us. Do we have a question?
I don't actually have a question. I just had to pop on the comment that if anyone is reading the end of the book before they stood at the beginning, that those people are the worst people in the world.
Oh, stop.
Derek, I was going to ask you maybe to drop Maria off this panel after you said that.
I could kick her out, but I'm going to let her on for a little bit longer here because she has some good insights. Besides that,
strike one, Maria.
Why not?
Priya, how about you? What's the most important part?
I think as Nish and Maria said, the agenda, and I just want to kind of reiterate that part because I think Maria touched on this where when the medical education providers, like you guys know the ins and outs of the proposal that you're developing and, the platforms that you guys are utilizing. And it's really hard sometimes for us to kind of get that vision. And I think the agenda really helps bring that proposal to life. So when we see a broad agenda, it's really hard for us to visualize what the program is going to look like. So as Maria said, I think as detailed agendas are really appreciated and as detailed as possible, it really helps us kind of visualize what that program is going to look like.
Yeah, and that maybe saves me from asking the group a question for later because a lot of people asked, how detailed do we get with the agenda? So it sounds like the more the better. Obviously, like Maria, you said with learning objectives, some things need to be a little more high level, but
right.
I like the visual that popped into my head, Priya, when you said it brings a proposal to life. That I can absolutely see how all that ties together, the format and the learning objectives, and now we put it into that agenda. And it's kind of like, how can I read something without going to the back first to see how it ends? How can I read this and see what's going to happen? So Ryan, how about you, Ryan, with what's the most important part to you?
So I would say two things, and my perspective is different, I'll admit up front, than the rest of the panelists. But for me, the executive summary, which Nish mentioned, we kind of took that to the next level. Back starting in May of this year, we launched a new template. It's called the Program Foundation and Accountability Template. And it has a table. It includes a table which asks the provider to show from the gap to the root cause to the learning objective all the way through outcomes. How is everything connected, and how does the story make sense? So like, for example, if the learning objective is clearly knowledge focused, are you going to try to get level 5 outcomes out of that, which makes no sense. So for me, when I read that, I know up front, to your point earlier, Mike, it's a red flag in some cases. So then it's going to really force me to read the whole proposal in more detail and see, does this really make sense? The other thing I'll mention, which I agree, agendas are important. However, if the instructional design of the overall program isn't done in a way that the program's going to be effective in helping change the behavior of the learners, then the information shared isn't going to matter. So I look at the instructional design and are there active learning components involved? Is there high level of interactivity? That's my perspective, because I have committee members who look at the agenda and the content, the scientific stuff. So that's their focus. I'm looking at the other, instructional design stuff. So that's my answer.
All right. Well, thank you. That's good perspective too. Derek?
So a question came in for Ryan. This is an actual question, not to make fun of Maria again. The question was about, you had mentioned that you put your RFPs on, it says in the question, the ACCME page or the Alliance page. I'm not sure. If you could clarify where you're placing your RFPs.
Oh, that's a good question. There's a place there. I have a link, but
is it on the Alliance website?
That has a link.
Yeah,
on the Alliance website. Yeah.
Okay, on the Alliance website. Okay.
The provider or supporters can post a call for grants.
Yep.
It goes there.
Yeah. Okay.
But again, I would say across all of our therapeutic areas, we might post 1 or 2 per year total.
Okay.
We just don't do it very often. So
yeah,
I wouldn't be looking for them every day because you won't see them.
I also mentioned to everyone, I've had a couple questions about budget stuff. I'm going to save those for the end because there's a small budget section at the end. So I'm just going to wait to address those. So if people are asking.
Perfect. Thank you. So let's jump ahead to needs assessments and references. Priya, you said this was a pretty important section of the grant for you. We have a couple of questions about how long should a needs assessment be, how much support at the gaps, etc. But why don't you go ahead and give us your perspective on that?
Yeah, I think it's always interesting for us to see, because before that full proposal comes in, the medical education providers, we kind of get, again, that snapshot as we're hearing the presentation. And so we have, I think it's interesting because we definitely see a variety of how that's presented, even when we're looking at the needs and concepts presentation, because we encourage 15 minutes and we see some folks that have, few slides, and then some, their needs assessments are like quite lengthy in terms of number of slides. So I would say we don't have necessarily like a set recommendation for how long a needs assessment should be, but I do think that for a needs assessment, like the clinical data is definitely essential in terms of helping us to see that you guys know the therapeutic area space, what your expertise is in the area. But I also think that there's a lot of data that, and also I just want to highlight, again, showing us that, the clinical trials, the guideline updates, things of that nature. But I also think that medical education providers have access to a lot of resources and data that we don't always get to see on a day-to-day basis. So for example, access to outcomes from prior programs, HCP or patient surveys, patient perspectives, KOL insights, interviews that you all do. And that data is also really great to see in the needs assessments, and also how it ties into the literature search that you have all done. So I would say I don't necessarily have a set limit in terms of how long the needs assessment needs to be, but those are the types of things that I like to see incorporated. And I kind of leave it up to the provider on, how they can best do that.
And so I have a question. This is my question that has always bugged me for, 20 or 30 years. If somebody, you said about the science and understanding the science, if you're reading a needs assessment and it's not necessarily identifying or expounding on the gap, but it's kind of almost the science that needs to be in the activity. Is that right or wrong, or yes, no, doesn't matter? Because I've read needs assessments where it's like 2 or 3 paragraphs. I'm like, oh, this would be great to tell the doctor, but does the supporter need to see this? But it also does show that we know the space.
Yeah, I think it's like also I think that's a great point, Mike. I think it's like thinking about, again, where does that belong in a section? Does it belong in your executive summary? Does it belong in your agenda? Does it belong in your needs assessment, and how that ties together? So I'm really thinking through how to bring the whole proposal together. So I do feel like it's really kind of thinking about which section it belongs in.
Good point. Maria, you had, when we talked before, talked about something. I hadn't heard this before. It makes total sense. Tell us about triangulation of gaps.
Yeah, triangulation is something that Priya just mentioned it. It's basically finding 3 separate resources that points at the same gap. And I wanted to reiterate this because it's very important. As budgets, at least as my budget gets smaller, I have to become a lot more choosy into what grants I'm going to be approving. And when you are looking at grants in such detail, I'm looking for gaps that would be backed up by outcomes, qualitative, quantitative, past surveys, thought leader comments, various things like that, to help me understand that you understand what my needs are. And sometimes it comes down to making sure that my data is in there. I'll do a control F to make sure that my clinical trials are in there, because a lot of people write really nice grants, but for me to truly understand that you're understanding my space, it has to come down to that. So a lot of things go into the decision. It's easy to decline a grant because if it doesn't measure up, that's easy. If there's a copy and paste and I'm looking at a lung grant, but a breast cancer data is in there, goodbye. But it's hard to approve a grant because there's so much competition and really good grant writers out there. So that's my take on that.
And I hope you don't mind me saying this, but in our prep call, by the end of it, Maria said to me, "Ooh, I feel sorry for you guys."
I do. My heart goes. I do. I hit the decline and I go, oh, I know they did so much work, but not everybody can get a trophy, unfortunately.
It's not a participation trophy, that's for sure. All right, let's move ahead to tying together. We've covered this a little bit already, but tying together these gaps, the root causes, learning objectives, instructional design, outcomes. I think a couple of you had talked about that path. Ryan, I'm not sure if you wanted to say anything else about that, but we have questions around what exactly do you look for that confirms that a proposal has created this clear line of sight from identified gaps at the beginning to measurable outcomes, presumably at the end?
I guess I already mentioned it earlier with the table that we created, because in the past, some providers would create a similar table, but it never included all the different pieces that we're asking for now. It had maybe the learning objectives. It just didn't show the whole kind of journey. So that's why we created it, and it's really helped. At least it's helped reduce my review time. It's helped me really focus in on what to look for in the full proposal. That I also read through the whole thing. But it just tells the whole story too. Like, is it good and does it make sense with the way it's set up? So,
Anish, I think you had mentioned that as well, that that line of sight. Somebody used that term in one of their questions, and I love that.
Yeah, exactly. Kind of what Ryan said, making sure that everything kind of goes in a line, right? Makes sense from the very top of the grant, right? From your gaps and root causes all the way through. Is so important to kind of, as Priya said earlier, bring that that program or that proposal to life.
Yeah, the root cause term I had not seen until the last year or two, and that's become more of I don't want to say a demand or request, but more something that we've been trying to do. So it's, for anybody that doesn't know what that is, and Ryan and Anish both use that term, so I'll let you expound on it. But root cause, if you don't know the cause of the gap, how can you address the gap? Is that a good definition? So some people have asked,
right,
what are best sources? Like, what do you consider a source for root cause? I guess along the line of references within either that table or the gap itself.
Well, we're looking for evidence-based. I mean, so what's in the literature? Because you can quickly do searches and find something, and it doesn't take that long. It does take some skill. When I try to do my own searches, it does take skill to find like the really good references, the more recent references. You have to know how to do it, but they're there, and you can find the ones that support the gaps pretty easily, I think.
Okay, perfect. Any other thoughts, questions about that tie in there? Okay, fantastic. Program tactics.
Sorry, Mike, I was working on getting rid of that little background noise. One question that came in I think that would fit in this section. I'm actually going to bring it up here. I have to find it. Nope.
Is anybody frozen? No, everybody.
No, just me trying to find.
So what process do you use to align with your medical directors or strategy team to create and update strategy? Monthly meetings, quarterly meetings, cyber grants portal. So I'm taking this question as you work with your strategy team, your medical affairs team, et cetera. Where does the strategy come from, essentially? Where does it come from, and how do you make sure it continues to be up to date?
So I could chime in here. So I get my IME strategy for each of my therapeutic areas from my medical team. And by being part of their monthly conversations as part of a full grant, part of a full team, they're discussing their pivoting or their needs at particular areas of time. And it's based on data releases, right? If something comes out better than what they had expected, I'm supposed to pivot my IME strategy. If data does not come out as expected, once again, I'm supposed to pivot my strategy. So I'm at the table, I'm having those conversations, I'm sharing what I'm learning through my outcomes to contribute to those strategies. And it's just an ongoing thing.
Yeah, so you have active involvement.
Yes.
Through the outcomes, and that's important.
Right. That's why the outcomes are very important to us, because we use those for many different ways to show our value.
Great.
I
Anybody
can
else
add my
go for it.
Yeah, because ours is a little different. So we work with our medical affairs colleagues. We update all of our strategies once a year, because the process literally, we start in about April, May, and it takes until the end of the year. So it's a long process. If it's a new area, a new disease area, and ours are at the disease area level. So like we're working with our med affairs teams who also have, what they call clinical care gaps. Like for each disease area, there's 1 or 2 key clinical care gaps. And so everything we do, we make sure those align to the clinical care gaps. So as they're developing those, they identify what are key, like is it around screening and diagnosis? Is that the key gap? Because if patients aren't being screened, then they're never going to be able to use our treatments that we have available, right? So we all align on that. But then I do drive myself the IME strategy. But I work with them. I make sure that we identify these are the key gaps, and then what are the root causes. And then we also look at internally what are the strategic initiatives or that's important to the company, and then we create our strategy based on all those points. But it only happens once a year, and then if it's, like I said, a brand new area, then we just start and work with them until we create it and get it ready to go. So,
and I'm guessing this is a great opportunity also to show the value of what you're doing.
Yeah.
The value of CME, the value of supporting CME. Anything specific there that goes into the strategy? Niche, jump over to you.
Yeah, I mean, I think in terms of the value of CME, right, you always want to be sharing outcomes with your committee, with your cross-functional teams, to ensure that the grants that we are supporting, it doesn't stop at supporting the grant, right? We're sharing those outcomes and those successes or failures, right? That's also equally as important, right? Why something maybe wasn't successful, and maybe we need to pivot our strategy or change it in some ways, right? And really aligning that with different areas within our medical affairs team. For example, if we have qualitative data from 5,000 learners, being able to tie that to what an MSL hears in the field, and making sure those thoughts and those ideas and things either align or don't for some reason. So I think all of that brings value to medical education across the organization.
Yeah, agreed. And this is a little off topic, but at Alliance this past year, the Regeneron team had presented how they talk about the value of CME. And one thing that really resonated with me was saying everybody else in the organization is buying data. We are creating data. So nobody else can do that. When we show them, like you said, qualitative data from 5,000 people, they're not going to get that anywhere else. So super valuable for CME.
No. And just
I think
to add to
one more
that,
thing I can add is I think another value.
Go ahead, Ryan.
Sorry, Maria, go ahead.
I was going to say, just to add to that.
Okay, sorry. I was just going to add.
Go ahead,
Ryan. I think
go.
we got a little delay with you for some reason, but so you go ahead. Maria, hold off.
Okay, so I was just going to add another point about the value of CME is, we have sometimes if a product gets approved for, an indication, and then we're studying it for other indications that aren't approved yet, IME, at least Lilly, it's the only area that we can continue doing education because it's independent. So like our medical affairs teams can't do company led in those kind of new indication areas until they have a label. So that's another kind of selling point. We're the only area that you can use as a channel if you want to educate these physicians if it's not yet approved. So yeah, that's key.
Great point. Go ahead, Maria.
I agree with you, Ryan. I'm happy you went before me. But what I was saying was, yes, we do get a lot of really great learner numbers. But what I'm still having a hard time with is they're looking at the number only as the only value. And what the my IME colleagues are still trying to show that we're more than just a big, pretty number. We go deeper. We could change behaviors. We could change competence and skills. And we make sure that we stress those type of outcomes as well.
Yeah, sometimes I think, and we'll get to this a little more in the outcomes section, but sometimes I think that's the easiest thing to understand, the butts in seats. And when we, as an industry, talk about competence and how we're changing behavior, that's a more complex discussion that I hear from your side many times.
Right.
I have one slide in 5 minutes, and how do I describe it in that short period of time? Let's jump ahead now to away from strategy. Now in the proposal, we're describing the tactics. So here's the activity, here's the instructional design. Ryan, I'm going to jump over to you because I know this has become a key driver for Lily's new templates with your checklists. And then the reason behind that checklist, I've heard the term word salad thrown around. I've heard, well, we just don't understand what the deliverable is going to be. So take it from there. Put that, describe that along with your checklist.
Well, I would say, well, we do have a checklist that we're assessing instructional design, to your point. But I think it also goes back to, in the table, we ask you to explain the instructional design kind of concept and why did you what's your rationale for choosing it? And then the next field is the format, because it kind of goes together in a way that has to go together. But then when we use the checklist to kind of go through, and there's several items on the checklist, but we're looking again for, I'm always looking for active participation. I mean, there's several, I think I would say over 50% of the items on the checklist are assessing just that. Like, is there feedback involved? Are there demonstrations? Are the learners, actively participating more than half the time? Those are key things we're looking for. Because again, it goes back to how effective will it be to change practice? And if they're just sitting there in their seats and it's a didactic lecture, they're not going to remember it. In 2 weeks, they're not going to remember anything, most likely. So.
Yeah, I think you kind of described that as learner involvement in the content itself, which is a nice way to put it. Priya, How about you? What are you looking for there?
Right.
No, I agree with Ryan. I think that it really is when we're hearing those presentations again over the summer, I think that how your needs and gaps are really tying to that education. How are you explaining your rationale for this type of format, for this type of design, for this audience? So I think really trying to bring it all together and explain your rationale is really, really important for why you have chosen that concept and why not another format, why not another instructional design. It really helps us understand that. So bringing that, really tying that, bringing that through. I feel like it's getting better. I feel like each time, as Ryan said, but I feel like for a while there it was a big struggle and we weren't seeing it. And I think people are being a lot more thoughtful and intentional.
Yeah, and I will say from my side over the years, not just Vindico, but other places too, we have the conversation. Why should we use this format? Why should we do it this way? And then sometimes you forget to put that in the proposal. Like, we know why we did it, but we didn't describe that. We wanted to get down to the nuts and bolts of what it is that we are proposing and what we're promising to deliver and what's going to end up, kind of now on that checklist that Ryan described.
So instead of when in doubt, leave it out, when in doubt, put it in.
Now, if everybody could just bump their proposal limits back up to 45 pages, then we're good. How important is it to have a novel platform or format in the proposal versus something that has been proven? So, we do outcomes. Well, it was a round table. We did the outcomes. It was super effective. Should we just not do that again, even though we proved it was effective, or does it simply get back to the why again? And Nisha, I'm going to throw this one at you.
Yeah, sure. So innovation, right? I think it's so important. I think all of our panel, probably every company would agree that nobody wants to stunt innovation. Nobody wants to be everyone wants to be on the forefront of innovation and pushing the envelope and things like that. But I think there's a lot of aspects that go into that. For example, budget. A novel program or format typically comes at a higher cost. So thinking about that when you are submitting for something that may be more novel. My advice to providers is always, like, if we haven't ever supported something with your organization in the past, maybe it's better to start small and then have some outcomes to look at before submitting that 300K plus innovative type of program. So thinking about that, and then also just not innovating for the sake of it, right? So thinking about the product life cycle of whichever therapeutic area you're submitting for. If we're early stage pipeline, maybe we don't need a level 5 program with all of the bells and whistles. Maybe just an awareness knowledge level program that reaches a number of learners and discusses disease state and emerging therapies and things will be good enough for where we are in that time within our product. So I think that's another important thing to look at before you just submit for something that's novel or new. But I think going back to what Ryan and Priya said, I think the most important aspect is the engagement, right? An engaged learner is more likely to retain the knowledge. So it doesn't have to be the newest format as long as it is something that will get the learners engaged and involved throughout the program.
You also said something in our prep call about accounting for clinician lifestyle.
Mm-hmm.
What kind of?
Yeah, I think that thinking about, for whichever therapeutic area, for example, if it's primary care where they're working across many different areas, maybe something like microlearning where they have the bite-sized 10, 15-minute program where it's easily digestible. They can do it kind of in between, their work or their job, or listening to a podcast on the way to the hospital or something like that. Versus maybe something that's more specialized where they need a bit longer, a little bit more time within that program to really digest the learning objectives for that initiative.
Great. Derek, calling Derek.
Yes.
I hear you have some AI questions.
Yes.
This seems appropriate with innovation here.
So we have two. I'll pull one up on here. And then I have some additional to add to this. So we haven't discussed the use of AI in proposal development. You share your perspectives on that. And then there's a little bit of additional context to that as well. Specifically, do you reject a proposal that you may have deemed that AI was used on? Do you use AI detectors? Do you require disclosure of AI usage? Stuff like that.
Yeah, I was thinking it was going to relate to program activities, but it's around proposals.
Yes,
right. It's around proposals. That's interesting.
Okay.
It's interesting.
Yeah.
I'll take a shot first. So I'm assuming that if you do use AI, just like I do here at work for different things, you're going to have that personal touch to it, and it's going to be reviewed. By looking at a grant and it just being submitted without that personal touch, of course, it's going to be obvious. But I have no issue with any AI being used, just as long as it has the components that we've been talking about for the past 40 minutes. With regards to AI and outcomes, I think that's a great idea. I'd see the output, the great output from it, as opposed to you not using it. So from a BMS perspective, and with regards to referencing it, this is the first time I've ever heard that question for a grant proposal.
It's not a scientific paper.
Exactly. Where you have to put that in. Anyone else have anything?
Yeah, I was just going to add, I've never rejected something if I thought AI was used to develop it, but if I check the references, because sometimes we all know it hallucinates. I've asked for references and it created out of nowhere fake references. And so if I go back and check your references and they don't exist, then I'm going to deny it based on the quality of the proposal. So that could happen if it doesn't exist because AI was used and it hallucinated.
Right.
Does that raise concerns to both of you? Would that raise concerns? Obviously the hallucination part, but would you have any concern if someone used AI to develop a proposal about what they're going to do when it comes to the scientific content of the activity? Or are you like, nah, that's the proposal team, that's the scientific team, I don't relate those two together?
Like Maria said, the purpose is to help us, make things faster, maybe take a lot of information and, make it easier to digest, faster. And you still have to have the personal touch. I mean, if you don't do that, it's going to be obvious. But as long as it all makes sense, use of AI is only supposed to help us. So yeah.
Okay. I know we have 10 minutes left and we still have so much to cover. So I'm going to maybe jump around to some key questions. We talked a lot about agenda already. Quick question about faculty. I think we've all learned over time that some people can get faculty names, potential faculty names, others not. I think Maria, at one point during our discussions, you said you wanted to see, or maybe you would see if faculty was involved in the creation of the agenda. Does that mean they're going to be on the program? So kind of where, short answer around, how important is that? Is it better to have names? Is it better to know what kind of qualifications and who is being looked for? We know from our side that we could give you 10 names for a symposium in the fall and maybe none of them become available because stuff comes up.
Right. I think by putting faculty in could be a little bit of a fake news. I don't rely on what faculty names are in there because, like you said, Mike, it might or might not happen. So I basically scroll through. Sometimes I don't even see faculty in a grant proposal. Initially, when I started to review grants years ago, I heard that they weren't supposed to be in there. They weren't supposed to be in there so you wouldn't be influenced by them because we're not supposed to know name, date, time, faculty, all that other stuff. So I do not put a lot of weight in faculty in a grant proposal.
Priya, how about you?
Yeah, so from our compliance team has told us that, they really wanted to ensure that the IMED team is reviewing proposals solely based on, the instructional design, the content, the needs assessment, and how it aligns with our strategy, not based on the faculty that, is selected or being considered. So they have asked us to kindly request that faculty not be included. That being said, I do want to see, thought into what faculty you're considering. For example, if it's like a global program, are you considering just US faculty? Are you considering global faculty? That high level, if it's a primary care program, are you going to have a specialist and a primary care physician? Are you going to have patient, the patient voice integrated? I want to see high level faculty considerations like that, but I don't want the names of faculty included for compliance purposes.
Okay, great. Just a quick touch on audience generation and dissemination. A lot of people asked about just how much detail you want to see. How important is the big number versus the right number of people, the right audience? If somebody is promising 1,000 people on a virtual webinar or whatnot, is that a believable number? Would you rather see 300 of the right people? And then how does it get down to a cost per learner? We always see that thrown around.
Mm-hmm. Mm-hmm. Well, it's nice to see big numbers, but you have to be honest about your numbers because I will come after you. I will follow up. I will pull up the grant proposal and say, you promised me this. I got this. What are we going to do now? I don't think people are out to pull the wool over our eyes, right, Mike? You're not out to do that to us. More focused workshops or the right community group of people, you know, you have to understand that that's the design and it's going to be a smaller number. But just because you put 15,000 learners doesn't mean that that's going to be the only thing I'm going to consider. Because I say to myself, are they really going to be able to do that?
Well, and then you have to throw in OSP and what is the definition of a learner, et cetera. So hopefully people are defining that as well.
Yeah, and I don't see that as much in a grant proposal. That's a good point, Mike.
Yeah.
And Mike, Derek? I was going to add one thing.
Yeah, go ahead.
If I could. So we're very focused on asking for target learners because our call for grants always, mention this, who are the target learners. So that's the main number I want to see. Now, of course, when it comes to reporting, we still want to see the overall how many learners joined because that's important. But we still, when it comes to the outcomes, it's very focused on the target learners. But more concerning to me usually is the cost of audience generation because it's all over the board. And I know that providers have to work with audience generation, providers or companies, but I have no insight into how much that costs. And there's, the big providers, they do their own audience generation. And so why are their costs 10 times sometimes as much as some of the smaller, more boutique providers who have to work with the audience generation companies, and yet they're trying their best to just keep those costs low. It just makes no sense to me. So that's what I'm always flagging and sending RMIs to say, why is this so high? And we even have a field in our budget template that you have to explain the rationale for why these costs are what they are. And half the time it doesn't explain it. So to me, it makes me not trust, that they're being transparent with the cost because it's they're just padding it and that's for me worse. I'd rather just know what the cost is.
Yeah, and some of that is going to lead in. I asked Derek to come on because we got some budget questions. When we think about these budget questions, I also want to think about value. So some of that, I think, Ryan, turns to value. It's kind of what is the cost of making a pill versus what is the cost of saving a life, or the value of saving a life, I should say. So in my mind, I kind of put that there. And I think sometimes we struggle as a MEC to be able to put the value of what we do, a really good symposium and a proper audience and whatnot. How do we build that into a budget? So Derek, what are our budget questions?
Yeah, two questions. One slightly more general, one a little more specific. So we'll try to answer these quickly as we're getting close to wrapping up. First one is, what are the red flag items in the budget when you're looking at the budget? Are there any red flags? Is there anything in particular that you're looking for when you review the budget?
Derek, let's start with you.
Don't everyone answer at one time.
Priya, how about you?
I think I do agree with Ryan. I think audience generation is really high. I also think some of the ones that kind of get flagged to us by our compliance department is travel, meals, things like that. Especially if your company has certain meal limits, honoraria limits that you need to comply by. I think those are kind of some of the important ones that you'll see potentially may vary by company. So I would say travel, meals, honoraria are some big ones that maybe we don't talk about as often. So I wouldn't say there's any red flags, but I think it's just something to be
I can mention
Oh, sorry, Ryan.
It's okay. Sorry for the delay. I don't know what it is. I was going to say our budget template is, for call for grants especially, is built so that it shows what we will support when it comes so those areas that we'll support. My red flags are there's an other section at the bottom, and that's where sometimes new things that are added in, which may or may not be acceptable for us to support. So I really focus in on those. And like you said, sometimes it's, transportation costs or just things we can't fund that I look for. But then aside from that, I'm looking for things that are just way above what I normally see, the costs, for audience generation or even the content building the contents. It's all over the board. It's so hard to know what it really costs.
Derek, was this the second question you
had?
Yeah,
this is one. I mean, it's to Maria, but I think anyone can answer it. Just talking about budgetary constraints, how often do you request a lower amount from the CME provider? So, I can't give you 500,000, but based on budget breakdown, could you do 450 or something along that line? Contingency plan maybe is what.
Yeah. Oh, well, I've been asking for contingency plans and grants for a very, very long time.
Yeah.
That does not happen. I don't know why. maybe because you want to have that dialogue with me. But if something's 500, that's a lot of money for one grant. I would never come back and say, can you take 450? I'm not negotiating. It's just, I'm using a little bit of the knowledge that I have with that, what I have in my budget, the knowledge of the people in my space, and the full amount of the grant. I would probably just decline something that's that high. Now, if something was, say, 200,000 and I have 120, that could be a conversation, but 120 is a lot of money. So I think something would come out of it. And that would be a question, what would the grant look like if? But I would never say I have 100,000 for a 500,000 grant. It just doesn't make sense in my mind. You're going to take everything out of the grant proposal.
Yeah, I agree with Maria. I mean, I would ask for what are the scale down? Is this proposal scalable? If so, what are the scale down options and what that looks like? But trying to get, trying to fit a certain proposal that's been developed away into like such a small budget amount, you're really just compromising the integrity of the proposal and the way it was designed. So I would rather phrase it as what are the scale down options, and see what the provider is able to do to still preserve that integrity of the program.
Yeah, I think the last piece for us is just tying budget to value, right? So like, for example, when Ryan said audience generation, if you're partnering with like a society or an advocacy organization, and we know that, you're bringing a patient perspective or you're going to definitely hit the right learners like partnering with society, we'll pay a little bit more for that, but making sure that whatever is being requested makes sense for the value of that program.
Great. Well, I know we're out of time. So I am going to strongly suggest to Derek that we add this panel back for spring 2026 CME Palooza. We will see you then.
I think we easily could have gone for another hour. There's still questions we didn't even get to. So sorry if you did submit a question, but that was good. So speaking of commercial support, money. I love money. Who doesn't love money? Time for the CME Palooza scavenger hunt. Go to our sponsors page, Academy for Continued Healthcare Learning, ACHL. Look for the CME Palooza logo on there somewhere. Click on it and see what happens. Whoops. Move on to the next one. A survey. I love surveys. Who doesn't love a good survey? If you're on the live page, there is a link there for our CME Palooza Fall survey. It's only a few questions. Won't take you very long. We do. It is helpful for us to know who's watching, etc. Also, it does give us. We do use the information from that and planning subsequent paloozas, etc. So please take a moment to do that if you have time. And to view the next session, you can just go to the live page and click on the appropriate session link. The next one is. I have to flip over my page so I can find it. It's our 11 a.m. Eastern Time session. One step over the line, what's right, what's wrong, and what falls into the gray areas of accredited CE, sponsored by Helio CME and PrimeMed. And with that, we are going to wrap this one up. Thanks to all for participating. We'll see you on the next session. Thanks, everyone.
Thank you, Derek.
Thank you.
Thank you.